Hello, Secretariat. You able to hear me and see me?
Yes, sir.
Great. Thank you so much. Thank you so much. And my sincerest apologies to all the esteemed faculties who have joined on time, but I'm late. My apologies. My sincerest apologies. I can see that Dr. Kartikeya Mishra is definitely here. Good evening, Dr. Mishra, and our very good evening, sir, and our very own Dr. Parmar, our speaker of the day, and our faculty has also joined in. A very good evening to you too, Dr. Parmar, and to all the esteemed attendees and the panelists. A good evening. Okay. And we'll just start in another 60 seconds. Since it's all set, and I can see that Dr. Parmar point out and joined in again. Okay. Yeah. Good evening, Dr. Siva. Good evening, Dr. Thagraju. Yeah. So. Okay, so I think yes. Now I can see Dr. Parmar.
Yeah.
Dr. Parmar, can you see me and hear me clearly?
Some network issues.
Yeah.
Yes. I could go ahead.
Okay.
Yeah, please.
Perfect. Pleasure meeting you once again on this platform. Such an amazing experience. Thank you so much for sparing your time. It's always good to hear and learn more from esteemed faculties like you. A real great pleasure. Thank you so much once again for sparing your time this evening, Dr. Parmar. Yeah.
Thanks for such a nice introduction, Dr. Pawan, and I'm really thankful to be on platform, and I welcome all of you on this platform. And let us start our talk with this cytokine.
Yes, for sure. A quick introduction, and then we take a go ahead from our president of the branch, and then we just start rolling with it. Sure. So with that, I welcome all of you to this ENOC DG Connect webinar, which is from Association of Environmental and Occupational Health, and Delhi branch and Haryana branch, and then a part of Indian Association of Occupational Health, a body which works predominantly in the occupational health domain, and is trying to contribute its best when it comes to public health and occupational health. So it's series 2, issue 3, this fine Thursday evening. I welcome you all on behalf of AUSD and AUH. I am Dr. Pawan K. Gupta, member executive committee, AUHD, the Delhi branch of Indian Association of Occupational Health, and secretary for Haryana branch. And a very, very warm welcome to all of you for sparing your time. And let's the deliberation that we are going to have today is on the role of extracorporeal cytokine filter in sepsis management. I hope this is the topic that we are going to deliberate today, and we have been contributing on this platform through various webinars, and esteemed faculties like Dr. Parmar have been definitely given their best contributions. Thank you so much for the platform, for giving me the opportunity to moderate the session. And with this, I hand over the platform to President Dr. Kartikeya Mishra to please announce the for introduction and also for opening remarks and approving to take it ahead. Please, over to Dr. Mishra, please.
Thank you, Dr. Pawan. Good evening. Namaste, everyone. On behalf of Association of Environmental and Occupational Health Haryana branch, I welcome Dr. Kartikeya Parmar and all the delegates, Dr. Tyagaraja, Dr. Shiva, Mr. Rakesh Garg, and all the other delegates. So it's my privilege to introduce Dr. Kartikeya Parmar, who is an Associate Professor, Department of Medicine, BJ Medical College and Civil Hospital, Ahmedabad. Dr. Parmar is currently working as an Associate Professor, Department of Medicine, BJ Medical College, Ahmedabad. He has more than 15 years of teaching and clinical experience in the field of internal medicine. Dr. Parmar was awarded by Honorable CM of Gujarat for selfless and tireless work in COVID-19 pandemic on 15th August 2020. He also received the Corona Warrior Award by Ahmedabad Medical Association on 27th September. Currently working as a nodal officer for patient care in dedicated COVID-19 1200 bed hospital from 18th March 2022 till date for COVID-19 pandemic. More than 25,000 COVID-19 patients has been treated, including those with critically ill ICU patients. He also worked in swine flu pandemic 2015, leptospirosis outbreak in 2013, then hepatitis outbreak in 2009, and flood relief camp in Surat, Gujarat. So he has a very rich experience of working with various type of pandemics, and I hope with this session we will be having much more knowledge about this role of extracorporeal cytokine filtration in sepsis management. So thank you, Dr. Kartikeya, for sparing your valuable time for this webinar. I think Friday is a working day, so we have much less audience, but
Thursday.
whatever is there, we will utilize your wisdom and knowledge, and we will gain from this your health talk. So
Yes.
Please start your presentation.
Yeah. Thank you so much, sir, for giving that wonderful introduction. And that's a lot of achievement, Dr. Parmar. We congratulate you from the core of our heart for all this wonderful work that you have done. And we definitely look forward to learn more. Our audience may be at times on this webinar platform because of working days could be less, but then with this goes global because we circulate it on our various channels, on our YouTube channel, on our social media platform, whether it is Facebook, whether it is Instagram, whether it is Twitter, or whether it is LinkedIn. So we try to circulate these messages and these webinars all across. So audience is definitely never a deterrent for us. And this goes to masses. We have thousands of views, and that's what keeps us motivating that, okay, we are digitally connected and we are trying to benefit out of it, because this recording straight away goes to those YouTube channels. And we have amassed a library there now, which we are proud of, all because of speakers like you. Thank you so much.
I have seen that there are a large number of visitors on our YouTube channel, and this webinar watching is increasing every week.
Yes, sir. Yes, that's why we physical presence or the real-time presence, it does not deter us. We know that people will go, they will watch, and they will share the feedback. It always happens. And we are thankful to you for that once again. Over to you, Dr. Parmar, for your session. We will be good listeners.
Thank you so much, Dr. Gupta and Dr. Mishra, sir, and everybody on this platform. I understand, I mean, this is working day, and as you said that many of them, they may log in now, and offline also, this would help a single patient to treat and save the life of the patient. That would be a great help to the society and human ground. So let us start with this my talk on the role of cytokine adsorption device in patients with sepsis management, and it could be really a game changer, I would like to say, in future, when this has been explored more and more with the scientific research. And as we all know, and Dr. Mishra and Dr. Gupta, you said that about COVID-19 pandemic. I have seen this pandemic with my eyes, working day and night in ICU and wards in our COVID-19 dedicated 1200 bedded hospital. And this has led to a biggest global health crisis, of our lifetime. So there is accumulating evidence that a substantial number of these critically ill COVID-19 patients exhibit a dysregulated host response manifesting as a cytokine storm, or what we can say is cytokine release syndrome. So everybody working in this medical field who are doctor from MBBS or nurse or paramedics, they now knew the word cytokine release syndrome or cytokine storm. And even with the all available, standard of care with steroids and other molecules that stabilizes the storm, but still we are lacking somewhere to control this cytokine storm when it occurs. So this is a really promising area of treatment when these cytokine adsorption devices come, and they may change a game of the patient in terms of saving life of the patient. Critically ill patient, they are sinking, and I would like to say human loss is loss, right? So when once the patient succumb and they are passing away, everybody, relatives and kins and dears and nears, they experience a loss. So to save a single patient's life with knowing advancement of therapy, correct time of implementation of timely intervention with such devices, and save one patient's life with the device is a key to success. So with that, I'll talk upon the sepsis introduction and Cytosol, role of Cytosol device in this sepsis and septic shock, and practical consideration about this device. Next, please. Next, please. Yeah. So just to brief about the sepsis definition, it's we all know that sepsis once occurs, it is clicking in your mind about the life-threatening condition, right? So when it leads to multi-organ dysfunction and dysregulated host response, it is very, we can consider those patients critically ill. And the incidence of this sepsis is up to 95% per lakh population, 95 cases, per lakh population. And 9% of those population progress to the severe sepsis, and 3% they end up with the septic shock and they succumb to mortality. So when sepsis goes into septic shock, it is a really very, very serious and critical situation. And when we consider patient of sepsis that has got a septic shock, when the blood mean arterial pressure of those sepsis patient drop below 65 millimeter of mercury, then we can consider that this patient of sepsis is going into the septic shock. And when patient of sepsis experiences septic shock, that gives an immense mortality rate, kind of up to 50% or more, and it may lead to a multi-organ dysfunction syndrome. And it is very, very, very challenging and critical situation to tackle and recover back patient to the life. Next, please. So these are the third international consensus definition about the sepsis and septic shock. And I would like to highlight next. So in here, the sepsis, how they look into definition of sepsis in 2015 is, it is a life-threatening organ dysfunction, and that is too caused by a dysregulated host response to the infection. So it is a not only organ dysfunction, but it is a dysregulated host response hitting on the already failing organs with the sepsis. Next. So it's organ dysfunction plus dysregulated host response, as I have said you. So it's a double hit on the patient, and the patient end up with the cytokine storm, and the body becomes its own enemy. When cytokine storms occur, own immune system attacks everywhere in the body. And in this dysregulated host response, removing cytokines, which are the real enemies that are causing the dysregulated situation, may help to regain the control of the situation and retrieving patient from the end stage of critical ill condition. Next, please. So here is the Cytosol adsorbers. You can see the device, and it is composed of highly biocompatible porous polymer beads with numerous pores on the surface. You can see on in the device there is the multiple porous beads are there, and each bead is roughly the size of a grain of the salt, and it acts like a tiny sponge, that sucks or attaches the noxious cytokine molecules to remove the substances from the blood based on the process of the adsorption. So relevant surface, the relevant surface adsorption with this tiny grain of salt like sponges is huge. When they are combined, the surface area would be more than 45,000 square meters. So it's a huge surface area situated in a compact, really compact device that works magically in filtering the noxious cytokines in patient of the sepsis. Next. So there are filtrations available. We all know about the dialysis and other filtrating like plasmapheresis that clears the blood from the certain particles, versus these adsorption devices. They have got a huge spectrum of, clearing the molecules that are dangerous and harmful to when they are accumulated in bad situations like sepsis. So say in membrane filter, like dialysis works on the principle of diffusion of the certain solutes, and ultrafiltration of the fluid across the semi-permeable membrane. So we know that hyperkalemia, high pH, high H plus ion, they have been filtered with this membrane filtration techniques. But versus this Cytosol adsorber devices, they works on principle of the attracting and binding the molecules. They are defined to bind and adsorb, right? So they have got a huge potential, like non-dialyzable substances like IL-6, IL-10 and TNF alpha. Here, when you plug, I will come to the next slide in how these filters are used, adsorption filters. But just to say that you can plug it into the dialyzer circuit, and dialyzer circuit, when you plug it in, it will filter the non-dialyzable substances like IL-6, 10 and TNF alpha, which are the key players in cytokine storm. Next, please. So this device, one more charm is this device adsorption technique works on the concentration dependency. So how this works? When these cytokines, these are the harmful cytokines in case of cytokine storms, when they are high in concentration, this device will adsorb these molecules in a higher removal, with a higher removal efficacy. So higher the concentration of the substances, this device will highly efficaciously remove those of the substances. And when they are in a low concentration, this device will filtrate it in a low or no removal fashion. So no complete removal of over treatment is possible. Say we need certain substances, like we need albumin level, we need certain cholesterol molecule level in our body at certain baseline level. So this filter, when it is used, these are kind of low concentration molecules. When they are not built up in the body, this filter won't filter it. When this cytokine storm, say for example, IL-6, IL-10, IL-2 and TNF alpha, when they are in storm, in high concentration, this device really looks those molecules to attach and soak, and this will filter in a high filtration efficacy, with the high filtration efficacy. Next. So these are the spectrum of molecules that Cytosol removes. It is a broad spectrum of cytokines. You can see from IL-6, IL-8, IL-13, TNF alpha, and you can see on the spectrum that certain bile salts, bile pigment thing and albumin things, they don't filter. I mean, kind of globin part of hemoglobin, and certain those are required in the body. They won't filter much with the this filter, and this has got a highly size and concentration selectivity approach with the this adsorption device. Next. So this device is very easy to set up in whichever condition you will require. Say cardiopulmonary bypass, I will come to in this couple of slides. When you are a cardiac surgeon, they are handling the complex cardiac surgeries. There are certain molecules, non-pathogen associated molecules, and tissue handling will cause release of certain noxious stimulus that will build up the immune system and cause the cytokine storm. So in those conditions, you can use this extracorporeal membrane device Cytosol device to tackle those cytokine storms during the cardiac surgery. So cardiac bypass surgeries, hemoperfusion, and renal replacement therapy, continuous renal replacement therapy like hemodialysis, and ECMO patients. A lot of patients with the COVID-19 have seen that they required the ECMO therapy, and those patients with the continuous cytokine storm, we could not give certain biologics intravenously or parenterally, or antibiotics, they have got limitations to tackle this situation. And here, this is the time to really treat the patient with these Cytosol absorption devices to tackle the cytokine storm. So it can be easily plugged in. You can see in all the situation, filtration, extracorporeal filtration circuit, it can be easily plugged and managed to filter the noxious stimulus built up in the body. Next. Next slide, please. Yeah. So these are the different therapeutic or treatment field indications to use the Cytosol device. You can, use in case of removal of inflammatory mediators when they built up like septic and vasopressor shock, septic shock. As I said, like COVID-19 is a key now emerging when, fortunately, we pray for not coming, COVID-19 cases won't come across the world, because we have faced the very bad situation and crisis of our lifetime in a healthcare system with this COVID-19. But still, COVID-19 patients who are going into the cytokine storm, experiencing sepsis, septic shock, this is the really working device, I would like to say, to save the one patient's life in those COVID-19 patients. Cardiac surgery, as I told you, that the tissue handling and certain cardiac conditions, they are precipitating the cytokine storm. And cardiopulmonary bypass surgeries, when they are timely intervened with this cytokine absorbing device, the Cytosol, the patients won't go into the cytokine storm during surgery, and that will give a great benefit. Even when you have a restriction about the patients with the cardiac surgery, you would like to give a certain anticoagulants, and patients are likely to respond weirdly to those anticoagulants and may bleed catastrophically because they are going into the cytokine storm and dysregulating immune system, inflammation, and causing much bleeding that is delaying the wound healing. And this all can be prevented when you timely intervene patients of cardiac surgery who are going into the cytokine storm during the surgical procedures. Emergency cardiac surgery again, and so on. Next. Liver failure and rhabdomyolysis. They are also one precipitating condition for the cytokine storm, and this device is really helpful. Next, please. So this is a kind of you can see when patient of sepsis due to pathogen associated molecules, patterns, they are tricking the immune system, or damage associated molecular patterns, particularly cardiac surgery, as I have told you. So this tissue handling and damage can cause certain molecular like DNA and mitochondrial substance release that is activating and hyperactivating and dysregulating the immune system, and that is precipitating the cytokine storm, ultimately ending into the septic shock and multi-organ dysfunction syndrome. So when you standard of care for the patient who are going into sepsis because of infection or some other surgical precipitating factors, you resuscitate those patients when they start succumbing with the O2 and volume therapy. When patient goes more into more severe situation, they are needing the vasopressors like catecholamines. When they are experiencing the septic shock, you escalate the dose to maintain the blood pressure and perfusion to the vital organs. But when the patient is in a gross cytokine storm, even these drugs have got limitations, and you try to source control with antibiotics. You support the organs, that on end organs like heart and kidney and so on. And when it fails, this is the time really to intervene with the Cytosol device. So this will be a game changer when you use it in the first 6 to 24 hours when you are juggling with the source control, resuscitation, you could see that patient is sinking with the septic shock and going into the multi-organ dysfunction syndrome clinically and lab-wise. So this is the real time when you react with the Cytosol device and treat the patient early with the Cytosol device, and this will really give a promising results. Next, please. So systemic inflammatory response syndrome, patient has start sepsis, goes worse into the sepsis even with your standard of care, and patient is progressively unstable with the septic shock and multi-organ dysfunction syndrome. So don't wait. I would like to say, just give every possible benefit and advances of the science to recover those patients. And this is a really Cytosol adsorption device is a key when you cannot juggle with the antibiotics, vasopressors, and patient sinking in front of your eyes. You just give a benefit of this device and you see a magical response when patient cytokines, noxious substances, they have been selectively filtered with this device. Next. So it works in every spectrum of this sepsis and septic shock, and it protects really of capillary integrity. When patients has got a capillary leak, we know all that cytokines and these inflammatory mediators, they cause endothelial dysfunction and endothelial gap junctions, and they are causing leak of the plasma into the third space, and that is how patient will succumb with the hypotension and hypoperfusing to the vital organs like heart and kidney, and eventually that goes into multi-organ dysfunction syndrome. So it works at every level, like it improves the capillary integrity, reduces the vasopressor need when used timely, improve the microcirculation, and ultimately perfuse those dying organs and improve cardiac function and renal function with increasing the capillary integrity and blood pressure of the patient. Next. So this is one of the study presented from the Austria. They have, it has been published in 2020, and they tried in 2 arm patients, 42 patients in each arm, total of 84 patients. And, yes. So they just did hemoadsorption with the Cytosol in septic shock patient. And what they proved is they use this device in 42 patients who are needing CRRT, end-stage renal disease and requiring the continuous renal replacement therapy. One group of patients with this condition has been given benefit of this device when they are in septic shock, and other they have got a standard of care with the control arm. So what they have seen is they have studied about the PaO2 FiO2 ratio. They checked about the requirement of the catecholamines, vasopressors, and they see the SOFA score, right? Sequentially organ failure analysis score. And what they found is, next please. Thus, when you use in this device with a timely intervention within 24 hours, the patients who have been given benefit with septic shock and CRRT, they drastically reduce the catecholamine need to 0.26 microgram per kilogram per minute, as I said, in 24 hours. And those group of patients who have been benefited with the Cytosol device, they rapidly recovered from the multi-organ dysfunction syndrome. Next, please. So shock reversal is quick and sustained in these Cytosol benefited patients versus those matched control patients. They have not shown any benefit of reducing the catecholamines. That reflects that their blood pressure has been not achieved that can perfuse organ well, particularly end organs, and those patients have got more mortality than those patients who have been given Cytosol adsorption device. And this Cytosol device treated patients, they really came up with the blood pressure. They have got well perfusion to the end organs in next 24 to 48 hours, and then rapidly reversed from the septic shock. Next. So they have analyzed the in-hospital as well as 28-day mortality. And what they found is there is significant reduction. You can see that in-hospital mortality is only 15 versus 26 in Cytosol and match control respectively. So there is around I would like to say 65% more benefits to recover those mortality situated patients with the Cytosol. Next. So these are the couple of studies published with these devices and experience of successful outcome with this device. Adsorption in the management of septic shock. Not only septic shock, refractory septic shock has been reversed, with this device when it has been timely intervened. And a lot of other indications like snake bite induced septic shock and immune dysregulation that cannot be tackled with the vasopressors and steroids and other things. That this device has, gave life to the patient when it has been timely intervened in those group of patients. Next. So this is again a study published in World Journal of Critical Care in Medicine. And they have also noticed the promising role of this device. What they said is in this study, they have evaluated the outcomes of 100 patients admitted to intensive care unit with sepsis. And what they observed is 40 patients out of these 100, they drastically require less dose of vasopressor when they have been given this Cytosol adsorption device benefits. So quick recovery of the blood pressure and quick recovery from the septic shock has been indicated. And those survivors also had a reduction in all biomarker levels like procalcitonin. We know that this is a marker of sepsis, C-reactive protein, again inflammatory markers, serum lactate and bilirubin, and inflammatory markers like IL-6, TAN, and tumor necrosis factor. All has been, drastically reduced. So by mean to say this is that patients, when timely intervened with this device, definitely shows a drastic reduction of adsorption of all these inflammatory mediators, and patient will recover quickly with this Cytosol adsorption device therapy. So again, they noted significantly that 28% of patients who are given Cytosol therapy less than 48 hours, I would like to say, after onset of sepsis, their shock has been reversed and they have survived well with the mortality benefit. So early intervention and timely intervention, this device is the key. Again, in this study they said that 40 patients out of 100, they survived, and they have observed that the survival outcome was better in patients where Cytosol was used within 48 hours. So early intervention, when you see the patient, you try the standard of care, you just try to control the source with the antibiotic, just to say, and you just give vasopressors to control the septic shock condition. And those group of patients, when they do not respond with those group of standard of care in 24 to 48 hours, don't wait much, and you use this device to filter the noxious cytokines and inflammatory markers, and the chances of survival is very high when you timely intervene with this patient. And one of this study, they also said that the reduction of the ICU stay is seen in patients if Cytosol is initiated in 48 hours, less than 48 hours time of septic shock. Next. So early would be the better, right? So early intervention, timely intervention, and best outcome and mortality benefit with this device. And so initiation of this Cytosol with patient with septic shock after onset of septic shock is a key. And early, you can see on the left side, the two bars, number of patients, you can see when the patients with the septic shock in less than 48 hours, when they have been given benefit of this device, the survival numbers are high compared to those when they are given Cytosol benefits more than 48 hours after the septic shock. Still, benefit is there, but significant benefit would be there when you use this Cytosol device along with the standard of care when they fail in 48 hours of the septic shock. So early would be the better. Next. Again, the vasopressor needs. You can see Those who are survivors on the left side of the chart, bar chart, pre and post condition you can see, and in non-survivors even. So in pre and post condition, you can see the drastic reduction. You can see the dark gray bar. You can see the vasopressor need overall is much less in patients who have been given this filtration device pre and post conditions. Next. Again, this is one of the study published, and this is a prospective study. Multi-center investigator initiated study to evaluate the clinical outcome with this Cytosol device in patient with sepsis and septic shock. So what they found in this study is 45 patients with sepsis and septic shock were studied, and post-therapy 26 patients survived, huge number. And dose reduction in norepinephrine and all vasopressors was 51%, 69.4%, and 13.9% in terms of norepinephrine or epinephrine or vasopressin usage. And interleukin-6 level reduction was found about 52.3%, and platelet count improved significantly in those group of patients who are experiencing sepsis and DIC to 30.1%. Mean acute physiologic and chronic health evaluation and sequential organ failure assessment score also has been significantly improved in those group of patients. So predicted mortality before Cytosol therapy was 56%, and mortality with, after this use of device is reduced to almost near to 50% after this therapy. So the survival rate when you intervene timely with this device is huge. Even 1%, I would like to say, survival in patient with the sepsis and septic shock would be huge. If you refer to standard of care or standard textbook about the sepsis, those textbook also says that is when patient goes into sepsis, septic shock, and sepsis and septic shock, they are like have got a 100% near mortality, and 16% when you have a huge setup, great setup, 16% mortality is still there. And achieving mortality benefit of 48.8% after Cytosol therapy in those group of critically ill patients is really big number. Next. So yeah, this device has got a great favorable safety profile, and as I told you in earlier slide, there is a no significant removal of the albumin, and there is a no significant removal when these needed molecules in the body, they are in a low concentration. This filtration device will not filter and keep their level at optimum. No removal of the, again, coagulation factors and immunoglobulins that are needed to fight the infection. No complete removal of the physiological mediators. Highly compatible porous polymer beads are there, and no activation of coagulation and complement system. So safely used in patients with the cardiac surgery and those requiring anticoagulant in case of cardiac surgeries. Only very low loss of platelets, so it is also benefited in those group of patients. Next. So how about we see this device in a practice and practical consideration of this device. Next. So there are huge potential indications for this Cytosol therapy nowadays in ICU patients. Patients who are experiencing refractory septic shock, not only septic shock, refractory. Those group of patients, they really, drastically and magically respond to those molecules. Vasoplegic shock, post-operatively or with ECMO therapy. Toxic shock syndrome, those who are infected and going into this TSS, necrotizing fasciitis, meningococcal, hemophagocytic lymphohistiocytosis group of patients, they are going into the cytokine storm, pancreatitis, burns, trauma, snake bites, I would like to say, and many more indications they are unraveling with this device as we use this device in those cytokine release syndrome situation. Next. So this is the bedside patient selection kind of tool and checklist tool, how you can select and patient profile when you would like to use in those patients with the sepsis and septic shock. So these are the scoring system. You can see on the top severity score, they are number 1, 2, or 3, and you have a clinical variables in the left column like mean arterial pressure, septic shock, acute oliguria, serum creatinine of the patient, whether they are requiring renal replacement therapy, arterial hypoxemia, mechanical ventilation, and inflammatory markers like serum lactate, procalcitonin, CRP, and the patients with a sequential organ failure assessment score. And all with this parameter, you can number them according to the values to score 1, 2, or 3. And on the right half of the slide, you can see how you interpret those scores. When patient has got a score of less than 8, that is like if patient is hemodynamically unstable or develops organ dysfunction, start counseling patients to use and benefits of this device when it has been used early. So less than 8 score, you can use early. 8 to 13 numbers of the score, definitely you just go with the Cytosol absorption device therapy benefit to the patient. More than 13 is a kind of little late intervention, but still patient might lead into the refractory stage where aggressive Cytosol therapy might be required. Like you just give one cycle and wait for the response, check the inflammatory markers, check the clinical status, and you can give a next cycle in 12 to 24 hours with the next another device, and you can see the response. Even the late, but don't hope lose the hope. Every life is important, and life a loss of life is lost, as I said. Next. So I mean, Cytosol therapy initiation, we can figure out from the score, from stable to patient. We can score them unstable patient is shock as refractory shock. So this is again the algorithm that says that you can use in different levels of the patient's condition. And when you give benefit of this device, begin early again within 24 hours. That will give a best benefit when patient is sinking with a septic shock. Next. Next slide, please.
Any issue with the yeah? Okay.
Yeah.
Yes.
So this is again the continuum of those steps of early use of therapy, and you can use the beginning of the hemofiltration and along with your standard of care, and you just go with the 12-hour, 24-hour, and day 2, 3, and sequential use of this Cytosol device in patients depend on the response, clinical as well as the lab. Next. So start early is a key. Catch your patient with the scoring system or clinical and lab-wise judgment, and give benefit of this Cytosol patient that will give high number of success and statistically significant benefit in patient with the sepsis shock. So right patient in a right time with the right therapy on top of that standard of care and right duration. So continue all the therapy until the patient is hemodynamically stabilized. You need a significant decrease in vasopressor, and you keep the patient off the vasopressor, clinical stabilization, and improvement of the multi-organ dysfunction syndrome. So in right patient profile, in a right time, timely intervention, and the right therapy, explain to your patients, this is the therapy that can give most benefit on top of the standard of care, and give a perfect duration of the therapy that bring your patient to again a normal healthy life. Next. So thank you so much, and any questions or any queries we can invite now or later.
No, Dr. Parmar, thank you. This was a wonderful, I would say, illustration and one of its kind subject matter. As little as I know from the knowledge, all the knowledge that I have, little knowledge that sepsis or septicemia or septic shock is still in today's time gives shivers down the spine to best of the medical facilities in the country or the globe. This is one thing that probably the healthcare service provider never want to face. But yes, eventually they end up facing this, and yes, the mortality is quite high. It's an amazing talk, I would say, or subject matter which you chose today, and this is going a long way. There's definitely on a good that it is on this platform, and people would be able to see, go back and forth, and gain whatever they want to from this wonderful and amazing presentation that you have given today. Thank you so much. On that note, I have a couple of things to ask for sure. One thing is the availability currently, and since how long this has been in the world, and what population of medical domain is aware about it. Suppose there are like 100 doctors, so are treating, taking the critical care part, or who are facing the sepsis patients. What percentage of the population is aware about this particular innovation, which is very good as I see. And also then the next question will be on the commercial implication. Does the cost go very high? Insurance companies do support this, and most of the major healthcare facilities do have it. So these are two questions from my side, Dr. Parmar, please.
Yeah. So, I mean, good questions you asked, Dr. Gupta. And, I would like to ask, answer first that your concern is how long this therapy has been here.
Yes.
And second is which population among the doctors they are aware of this.
Yes.
So the thing is that before 2 years of COVID, I would like to say, so it has been more than 5 years or around 5 years, this device is available.
Okay.
And I have, I am working in Asia's one of the biggest hospital, that is Civil Hospital of Ahmedabad, and Asia's biggest hospital with the, we have 1,200 bed of COVID, dedicated COVID, and primary beds are around more than 10,000 with a different specialty. And I have used this device in many other indications, like patients with the meningitis and sepsis and septic shock.
Okay.
So one of the thing is that this device, as it requires the filtration circuit, so this kind of setup, those of dialysis machine or plasmapheresis kind of machine, they are required. So those doctors who are affiliated with the institutes, they are having this filtration machines or device which can allow to plug in this device in those machines. So that is the first requirement. And the physicians or those critical care specialists or patients who are looking doctors who are looking infectious disease patients more, they are the target doctors who can benefit the most with this device. We can get a benefit of this device, because the standard of care has got its own limitation. And once the patient sinks, we lose hope with antibiotics and vasopressors and everything. Nothing remains there to treat those group of patients. And this is really a game changer. I've seen 2 of my patients who are really coming back to life, after 24 to 48 hours with a single device filtration benefit with this type of device. So this is the kind of result this device can give. And you have to select the perfect patient profile and timely intervention with the timely decision, right? And with this device.
Perfect. Thank you. Thank you so much for taking those questions and answering. And regarding the commercial implications, so does the cost go very high once it is infused, like the usual treatment cost and this cost? Apart from definitely mortality is one thing that has to be prevented, and there is no cost that can balance the life. But then does it implicate the cost drastically, or is like minor difference?
I mean, when you use biologics to juggle and tackle this septic shock kind of situation, that costs certain times more than this device. So, and when you don't get a benefit, as you said, saving the life of the patient is remaining in the ICU for a longer time, it will ultimately cost much more than this device use. You just retrieve patients early from sepsis, bringing them back to the wards from ICU, discharging them early. As I said in one of my slides, the study says that when you use in 48 hours, the ICU stay, 28 days mortality and ICU stay reduces drastically. So ultimately, when you submit all this, the cost is not that concerned with this device when you educate and explain and discuss with the patient.
Absolutely, absolutely wonderful. Yes, Dr. Parmar, I completely agree. And these answers are going to help a lot of people, as you have wonderfully answered and taken the questions. I can see that his hand by Dr. Jan, our Senior Vice President, AUSD, IOS, Delhi branch, very senior faculty, highly learned. Dr. Jan has to ask something. Over to you, Dr. Jan, please. Good evening to you.
Yeah, good evening, Dr. Pavan. Thank you for giving an opportunity to ask and comment on Dr. Parmar's exposition. Dr.
Please.
Parmar, I must congratulate you for a wonderful, comprehensive presentation on cytokine storm management in the critical care units. A few questions that I have are, number one is, how can we identify patients and procedures that benefit most from the treatment? How can we identify patients and procedures that benefit most from the treatment?
Yeah.
And second question is, if or I may ask the second question later. I think that would be better.
Yeah. Thank you so much, Dr. Jain, for allowing me on this platform. And your concern is kind of which patient population, right, benefit the most, and how you can select this device. As I said in my presentation, you have one scoring system, less than 8 points or 8 to 13 points or more than 13 points, according to the clinical parameters and lab wise. You can have those facilities at your center or any center having those facilities. You can definitely count those scores and you implement inpatient with the sepsis. Like any patient who are experiencing sepsis and going into septic shock, and this standard of care, like you just control the source, like if it is infection or if it is a surgical procedure that is causing hypotension or pushing the patient into the septic shock, and you clinically judge and lab-wise judge confirm that this patient is having septic shock. Those are the patients when standard of care like antibiotics or vasopressors or other treatment which you have biologics that won't work and patient deteriorates in progressive 12 to 24 hours to 48 hours. This is the time. Don't wait. Don't try to juggle with the molecules like antibiotics. Giving antibiotics also precipitates some sort of tricky situations to the immune system. So use this device to absorb these noxious substances like cytokines, IL-6, IL-10, TNF-alpha, and patient will really, stabilize with the immune system, and patient will have got more chances to recover from the bad condition.
Yeah, got it. The related question is patients on ECMO. Now, in which patients with ECMO should Cytosol not be used?
See, those patients on ECMO who
Yes.
have got, patients perfusion pressure won't allow, right? The ECMO therapy, when you give it and the perfusion pressure is not that great, and when you go with the filtration, this filtration will precipitate more hypotension and causes a multi-organ dysfunction syndrome. So you just have to balance between those standard of care, like you use the vasopressors to keep the blood pressure at certain level and then give a filtration cycle to those of the patient. So ECMO, we can understand that juggling the life and death and almost lost the hope, but still perfusion pressure, no end organ damage, no multi-organ dysfunction syndrome, you can give benefit of this patient. You can give Cytosol benefit to those group of patients.
Okay. And the last question that I have is, which clinical or lab findings could be used to support therapy management, such as start or termination of Cytosol therapy?
So I said in
clinical and lab findings could be used to support therapy management, such as start or termination of Cytosol therapy. That's the question that I have.
Yes. Good question. You mean, I said in one of the slides, there are a couple of studies, and we also have experience at our side that we use Cytosol adsorption device use and post use certain parameters like IL-6, IL-10, and TNF-alpha. Those are the inflammatory markers. And procalcitonin, CRP, they are add-ons to these markers. When you use sepsis equal to, increase in all these markers. Cytokine dysregulation or cytokine storm equal to increase in those markers. So you just pre-filtration markers, look at the value of the pre-filtration markers, and use this device, and you can see the drastic reduction in those inflammatory markers, right? So washout of those markers, they are not then causing endothelial damage, capillary leak. They don't cause a sepsis going into the septic shock. And that is how we monitor with those inflammatory markers. So you have to have a specific lab support to measure those specific markers.
So you mean to say that lab findings would be more important than the clinical findings for supporting your decision to start or terminate the cytosol therapy?
Absolutely correct. So lab
Okay.
markers, they are key to monitor.
So how frequently you have to measure this IL-6 and IL-11 and how frequently you will
Yes,
measure
yes.
in a
I
critical care
mean,
setting?
pre and after say 6 to 12 hours, you can go with the 12
Okay.
after 12 hours, and you sequentially keep on watching those markers like 12 hour at 24 and 48 hours. If you have a graph of declining observation of decline of those markers, you just wait and watch and support, give all the standard of care. And if those markers, they are rising still after your use of this device and standard of care, you can wait for more 12 hours and monitor again, and then to take a decision to give a second cycle of this device in those group of patients.
Thank you, Dr. Kartikeya. It's really interesting, and thank you for answering questions that I raised. Thank you so much.
Thank you so much
much.
to Dr. Jan, and thank you so much to Dr. Parmar as well. Those were really illustrative queries, and as I keep saying, it's going to go a long way. I can see Dr. Thagraju, our one of the torch bearers, I would say, and a key faculty, a hardcore patient manager, and very supportive and very kind of the work that we do on these platforms. He has been very kind and very appreciative of this knowledge sharing platform, and he is utilizing it. So you're on mute, Dr. Parmar. Please, yeah, you're saying something? Yeah.
Yeah,
So,
yeah.
so
Go
Dr.
ahead.
Thagraju is here, and he has some question and queries. Good evening, sir. Over to you, please.
Yeah, thank you very much, Dr. Pawan.
Thank you,
Sir, Kartikeya Parmar, doctor, it's a very nice, one of the best presentation we have come across in the critical care medicine. Whatever you have said is very good. This one, your data is very excellent. Your treatment modality and concept, everything is good. See, we are the physicians, the practicing physician. We refer cases whenever the critical case comes. See, the moment we refer, we keep on asking, requesting the doctor, doctor kindly put them in general ward or the specialty ward. Please don't put them in ICU. Because, see, nowadays, my special request to you is, please, if it is possible, please ask the government to raise this insurance level whenever the cases like critical case comes, whenever the cases become the septic shock. In corona cases, we have seen plenty of cases of corona, of this one. And people who have migrated from, who have come from US, who was having about 40 lakhs of insurance, has been exhausted in one case. Then they have to arrange in an hospital like sorry.
No problem, sir. No problem. No problem.
Okay, go ahead. No problem, sir.
Yeah. I think, yeah. Yes.
So what happened? We really have to arrange 1.75 crores for a lung transplantation. After 5 days, the patient also expired. He is a very young man of 39 years. His wife is 32 years and is having a girl baby of 7 years old. It is happened in Aster CMA hospital, and 2 transplantation has occurred, and 1 transplantation was a anesthetist, emergency medicine doctor, and who could able to survive. For them also, it is a contribution from many doctors, and this man also a contribution this one. So my personal request to you is, why don't you ask the government, your data you can send it, to raise the insurance in case of whenever the patient is shifted from ICU to the septic, this kind of cases, because it will not be, I don't think it will be less than 25 to 30 lakhs. What do you say, sir, Kartikeya and Parmar? Whenever we admit a cases like this, it will definitely rise to 25 to 30 lakhs.
Yeah, I mean, over here, if I talk situation over here at our center for COVID-19, you said, but government has done like anything. They have supported like anything, and if you won't believe, we don't charge a single paisa to the patient. You know, whichever patient they took treatment at our center in COVID-19 hospital dedicated. So not a single patient, we have seen around more than 1.5 lakhs patients. They all get this, COVID-19 treatment or investigation or ICU care or ward care, everything at a free of cost.
Okay.
So kind of government supported like anything. But I mean, if you say patients who want to take treatment and benefit in a non-government hospital, yes, they require more budget to take care of these critically ill situations. So definitely the insurance has to be raised, but that is the kind of policymakers' decision, and those patients, when intervene timely, every patients need timely intervention. You have to pick a certain problems in a timely fashion. So, say for example, patient when goes into cytokine storm, you have to act very rapidly, very quickly. You don't have to wait to certain thing progress bad, or patient going into the worst situation. So early intervention will not only save the patient's life, give benefit in terms of mortality, but also reduces the financial burden. As Dr. Gupta said, this device is costly. If we think like that, then if think in other way that patient stays in ICU for 2 more days, it would equally cost patient to at par with this device. But when patient come out of the ICU, say 5 days earlier, that will really give benefit to the patient. Just like other diseases like diabetes, if you treat diabetes early and keep the diabetic control tightly, the diabetic complications, micro and macrovascular complications like myocardial infarction, brain strokes, and peripheral vascular disease, neuropathy, nephropathy, loss of vision, So we running a diabetic specialized OPD, and we to begin with educate the patient to keep their control of the disease very tightly, so they don't end up with the back end. At the back end, they don't end up with the complications, and that complications give more burden to the healthcare system than the cost of the treatment. So early intervention, perfect intervention, optimum intervention would be the key to lessen the healthcare system burden, and making the policy for the expenses.
Thank you.
My second question, sir. My second
Go ahead.
question is,
Go ahead.
you have given a very good answer, sir. Thank you very much. The second thing is, sir, we have found, as a general practitioner, we have found a statistics that where there are pulmonologists, where there are intensivists, where there are a super specialization like you, the come out of the cases like a septic shock, all these things is very better. But in certain cases where there are only an MD, where there are no pulmonologist, where there are no intensivist, where there are no emergency doctor, the outcome is a little bit less. Mean about the comparison is this one. So my kind request to you is, at least please raise this post graduation in the super specialization for at least coming to this one. But I should not tell. But after this BJP has come to the power, this many of youngsters are getting post graduation. It is really a statistics. If you see, BJP government NEET examination and all these things they are given. But my request to you is, you can write to the government to make, because nowadays see, I have informed you that a man who has worked in US for 10 years of 39 years has expired in Aster CME hospital. So his wife is not a working lady. They were in a IE family, has become to the low class, low middle class it has come. So please ask the government to raise post-graduation, super specialist post-graduation, more number of seats, more number of doctors, and even you can put it in this one, that those doctors who have utilized the government services should work for 10 years in a government hospital. That and all we respectfully, highly agree, but only thing is the human value should be there, and more number of patients should survive, more number of people should not die with this one. This is my request, sir. Thank you very much. Thank you, Pawan, for giving me an opportunity. You are the one of the best moderator which I have come across. Thank you.
Sir, you have been very kind and generous, and your concerns and questions are having a very, very broad vision. These are like global concern. This is not specific, region specific. It's all because of the humanitarian touch that you have in your heart, and that we keep saying that you are very patient centric. You always see benefit, how patients could be benefited. So we are really privileged that doctors like you are driving this from the front. The question, the request that you're making to Dr. Parmar are not related to any specific thing, Dr. Parmar, you would agree. These are like very broad policy decisions, which if could be done and implemented, it will help millions and probably a couple of billion people on Earth. That's how I can put it across. Thank you so much, Dr. Tyagarajan, for sparing your time this wonderful evening, and for your kind gesture, appreciating the efforts that we are doing. I can see that Dr. Sharma has also joined in. If at all he is available and he can unmute, Dr. Sharma is National Secretary for Indian Association of Occupational Health. He is also on the board of one of the key faculties on international figure in terms of ICO. So Dr. Sharma, if you are available, and please, over to you.
Thank you, Dr. Pawan.
Thank you,
and Dr. Parmar for having this session. We have heard Dr. Parmar earlier also.
Yes.
And yes, this is a very important topic, and he is the best person to deliver the details about this particular therapy and save the patients in septic shock, and especially during the COVID, these therapies they have helped, and they have come into the limelight.
Yes.
I'm sorry, I'm actually I was busy in some official engagements, and I'm driving right now, so I won't be able to.
No problem. I
talk
can
for a
understand.
long time.
Yeah.
Thank you so much, sir, for joining with
yeah.
us. You know, thank you. With this much busy schedule.
Yeah. And Dr. Parmar, we will be having our annual conference sometimes in October, and our OccuCon in February next year. So we would request you to block those dates also. For...
Thank you so much. Thank you so much considering me, sir.
Yeah.
We will
Shivang will inform you about the details.
Yeah.
Sure.
Thank you.
So
Thank you so
very
much.
much.
Yeah. Thank you.
Thank you, Doctor.
Yeah.
Thank you so much, Dr. Sharma, for sparing your time even while you are driving. Really appreciate it. That is what keeps us motivated.
Yeah,
the
sure.
dedication that Dr. Sanjay Sharma has, nobody matches that, and I agree, and I can say it loudly on this platform, which the voice is going to probably a million people, definitely, often and all. But yes, we are really thankful to you, Dr. Sharma, for all the efforts that you are making and being a driving force for people like us. With that, I really thank to you, and come to Dr. Shrikant Mishra for the remarks, and also if you have any question, Dr. Mishra, please. If comfortably available, yes, Dr. Shrikant Mishra, because he was actually held up, very tight schedule, definitely he had, and then okay, I think Dr. Mishra is engaged. But with that, Dr. Parmar, I think I will not hold anyone here more. We have spent an hour and 45 minutes now, and with the amazing knowledge and information that you have shared, we thank you from the core of our heart, and we'll keep inviting you. And
thank you so much.
Thank
you so much, Dr. Gupta and everybody, and for inviting me and being a part of this great event. Right. Thank you so much.
Thank you so much. Thank you. Have a wonderful evening, all of you. Thank you.